Head and neck cancer develops in the mouth, throat, nose, and salivary glands and affects individuals' quality of life and ability to function on a day-to-day basis. Head and neck cancer, tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host, Dr. Andrew Ellsworth. Tonight, our discussion will focus on the challenges and future perspectives of head and neck cancer. Head and neck cancer is a term used to describe a range of cancers that occur in the head and neck region, including the mouth, throat, larynx, nasal cavity, and salivary glands. These cancers can be challenging to diagnose and treat due to their location and proximity to critical structures such as the brain, spinal cord, and major blood vessels. As a result, patients with head and neck cancer often face significant difficulties in terms of treatment options and outcomes. One of the primary challenges posed by head and neck cancer is the impact it can have on a patient's quality of life. Treatment for these types of cancers often involves surgery, radiation therapy, and chemotherapy, which can result in physical changes in individuals, and these physical changes can have a significant impact on a patient's self-esteem and ability to perform even daily activities, leading to emotional and psychological obstacles as well. Despite these challenges, there are promising future perspectives for the treatment of head and neck cancer, which we will discuss tonight. Overall, head and neck cancer remains a significant trial for patients and healthcare providers due to its complex nature and impact on quality of life. However, with continued research and advancements in treatment options, there is hope for better outcomes and quality of life for patients diagnosed with these types of cancers. It is essential for patients to work closely with their healthcare team to explore all available treatment options and to access the support and resources needed to navigate the challenges of living with head and neck cancer. This evening, we are joined in the studio by Dr. W. Chad Spanos, who specializes in otolaryngology and head and neck surgery at Avera Medical Group ENT-Head and Neck Surgery in Sioux Falls, South Dakota, and Dr. Kyle Armeson, a board-certified radiation oncologist at Avera Medical Group Radiation Oncology in Sioux Falls. Welcome to On Call with the Prairie Doc.
Thank you. Thank you.
Kyle, you've been here before.
Yes, I was here back when Dr. Holm was hosting.
Tell us a little bit about yourself, Dr. Armeson.
Well, originally from North Dakota, so moved farms about 7 hours north of here, so we are enjoying South Dakota. We've been here for 10 years. My wife's also a physician at Avera. She's in palliative medicine, Dr. Francine Armeson. And we're glad to be here.
And where did you do training?
So undergrad was at University of North Dakota, and then we moved to Nashville, Tennessee. That's where Vanderbilt University was, and we did med school there as well as our residency training.
What brought you back here then?
Closer to home. I wanted to live more rural, live in a small town, have the countryside.
Excellent. Thanks for coming back on the show.
Of course, thank you.
And Chad, Dr. Spanos, this is your first time on the show.
Yeah.
Welcome, thanks for coming.
Thank you.
Tell us a little bit about yourself.
Yeah, so I have lived almost everywhere across the country, so Texas, California, Washington, Kentucky, and the question is always like, how in the world did you end up in South Dakota? And as part of the medical training, I was in med school in Kentucky, but then matched into residency training in Iowa. So I was in Iowa City for 8 years and got used to this area of the country. And when I was looking for jobs, there was a job that opened up in Sioux Falls, South Dakota, and here I am. And we've been here for about 15 years.
So you weren't disappointed?
No, it's a great place to live. Yeah.
Excellent, awesome. And so what do you do in your practice?
So in my practice, part of it is research. So I still run a research lab, but then as far as the patient side of it, I see people in clinic, but then I also do head and neck surgery. And in our specialty, we are also almost like the quarterback or the central home for the patients as they go through their head and neck cancer journey. So we help with the diagnosis, we help with formulating the overall treatment plan, even though many of our patients are primarily treated by Dr. Armeson or his colleagues with radiation, and then we follow the patients for years and years after their treatment to watch for recurrence, but also manage side effects.
And Dr. Armeson, tell us about what you do as a radiation oncologist in general.
Yeah, so in general in the radiation oncology, we treat all types of cancers. So it's not just head and neck. We're treating, from head to toe. But a large volume of our patients, do come through the head and neck world, just because Dr. Spanos and his team, have built such a good program. We're counseling patients on the role of radiation, about different options, the risk benefits of what a radiation course might look like, and then as working, with the patients closely to get them through the treatment, because to get the benefit of curative radiation, we have to get them through it and try to get them through it, as easily as possible, knowing that there can be a side effect profile.
And if to explain radiation oncology in layman's terms, like what are you actually doing when you?
So when we talk about a radiation treatment, it's a treatment with a beam of energy. So most commonly, we're using high energy X-rays. We have in our clinic, we have several different types of machines we could use, but most commonly it's a linear accelerator. It can make the radiation beam on demand. And what's really neat is that it's, with modern technology, you could really work to shape that radiation to be strong on the tumor and work and twist and shape the radiation away from those good tissues, the best we can. It's all about trying to come up with that risk-benefit ratio. How can we be strong on the tumor, but as safe as we can, on the normal tissue? Because that X-ray, it does have to go through the body to get to where the tumor is.
And sometimes you're treating to cure the cancer, and sometimes you're palliative treatment.
Right.
What's the difference there?
So when we're going for a cure, typically our radiation dose is going to be a lot higher, meaning that it's going to take longer. Curative intent in head and neck cancer, for example, patient might be going for 7 weeks of radiation, daily, Monday through Friday. When we're going for cure, to the best of our knowledge, all the cancer that we know of in the patient's body is going to be in the radiation field. We're trying to eradicate every cancer cell that's there. When we are palliating, it's often in a case where we don't have the option for cure. Maybe it's a patient that has stage 4 cancer where the cancer has moved in the body, and what we're really focusing on is an area where there's a symptom that we're trying to help. It'd be common that we're helping with pain with the cancers in a bone. Is someone having difficulty breathing because there's cancer by their airway, either in the throat area or in the lung, and we want to shrink that cancer down. When we're doing palliative radiation, we try to be more short and sweet. Maybe it's a one-time treatment, maybe it's a week or two. We're trying to do what we need to do to help without having the side effect profile, be as intense.
Yeah, excellent. And so, Dr. Spanos, as we start talking about head and neck cancer, what is that? What does that mean?
It's a catch-all term, and it really depends on what things you include in there. But in general, when we talk about head neck specialty, it excludes things in the brain, but it does include almost all other types of cancers. Now, for the sake of discussion today, we probably want to focus it just on, like you said earlier, cancers in the mouth, cancers in the throat, cancers in the sinuses. Those are really the ones that would classically be called head and neck cancer, even though you can have thyroid cancers, you can have salivary gland cancers, you can have skin cancers. That's not the vast majority of what we deal with in the head and neck cancer world.
So if someone has a head and neck cancer such as that, in the mouth, in back of the throat, what are some of the presenting symptoms?
So for the ones that are in the mouth, those are a little more straightforward because someone might find that they have a ulcer or a painful area inside their mouth that just doesn't heal. The dentist might be doing their regular dental examination and say, you've got a white patch on the side of your tongue. Those are the ones that are going to be a little more straightforward to find. The ones that are in the back of the throat, and especially the ones that are down beyond what a primary care doctor can see just by looking in the mouth, those are a little more subtle. Might be some throat pain or ear pain that just doesn't go away for several weeks. Might be, for some of the viral caused cancers, no pain, but I just feel like maybe I got this lump in my throat and it's been there for a few months. And so it can be quite subtle. For the laryngeal cancers, or what people would call like the voice box, then it would be some hoarseness, right? So for whatever reason, I thought I had laryngitis, but now several months later, it's not going away. I'm still hoarse.
Yeah.
And it can be as subtle as that.
And with, to put in perspective, so many of these symptoms people commonly have
Absolutely.
For non-cancerous reasons.
Yep.
But I think that's a good point, when it's not going away.
When it's not going away.
And that still doesn't mean it's cancer.
Correct.
You could have a hoarse voice because of silent heartburn or reflux.
Or maybe you yelled a lot at your kid's baseball game or whatever. But it's, I think the common theme that I see, and again, it's a selection bias because I mostly see people with cancer, but typically people knew that they had the symptoms, but they just didn't go in to get checked out. And as an adult, especially if, so I'll give you an example. An adult with a neck mass, 85% of the time, if it's there beyond 2 weeks, it's probably going to be cancer. And so just don't ignore things that pop up that don't go away as an adult.
Sure. Good wisdom. Good wisdom. So at what point do you see them then, usually?
So usually we're a specialty. So the front gate is usually with primary care or with their dentist or even other ear, nose, and throat doctors out in the community. Someone will find something, see something, take a biopsy typically, and then people then come to our clinic with a diagnosis of cancer. But we occasionally also see people who just walk in and they self-refer and they say, well, I've had this lump in my neck for a couple months, and we sometimes will do the diagnosis straight away.
So, they present to their doctor, which is a good idea.
Yep.
You don't need to wait for the specialist.
Yep.
Go see your primary care doc.
Absolutely.
They'll do an exam, come up with a plan, maybe have an ultrasound or some sort of CT scan or something.
Right.
They may have sent them to a surgeon, a regular surgeon, or an ENT surgeon, or some other radiologist that can get a biopsy.
Correct.
So now they've got a sample, and now we know they have cancer.
Right.
The most common cancer for head and neck is?
A squamous cell carcinoma.
And what is that?
So the analogy that I give to patients, because most people are really familiar with skin cancer. Almost everybody knows someone who's had skin cancer. And so this would be similar to squamous cell cancer of the skin, except it's just inside your mouth or in your throat. And it behaves the same way. It's just a abnormal growth of the lining. So if you think about your skin just on your hand, if those cells start overgrowing and not behaving, this is the same thing that's happening, except it's inside your mouth or inside your throat.
And of course with skin, where the number one reason is going to be from sun exposure.
Yep.
But my mouth isn't open to the sun very often.
Hopefully
I do
not.
a lot of talking, but
yeah, unless you're taking a nap outside and snoring, yeah. So the most common cause 40 or 50 years ago was smoking, and a combination of that plus heavy alcohol use. And you can have heavy alcohol use alone cause cancer, you can have smoking alone cause cancer, but the combo together is really highly risk associated with squamous cell carcinoma. Now, if you look at the tonsil area, or what we call the oropharynx, which is the tonsil and the base of tongue area, almost 80% of those are now caused by human papillomavirus. So we have two different groups. HPV, yep. And then there's actually a third group, which is really interesting, which is chronic inflammation and trauma. And so we see a certain number of people who come in and they say, I've never smoked a day in my life. I didn't do chewing tobacco. Why did I get this cancer inside my mouth? And those are usually some genetic predisposition plus repetitive trauma to the tongue that causes eventual cancer formation.
And what makes this, what are our theories on how HPV could even cause this cancer?
So that's been pretty well worked out, and it was worked out by our friends on the other end, which are the GYN oncologist or the gynecologist. HPV causes a certain progression of changes in the cell that causes the cell to stop paying attention to the signals that say don't divide. So the cells just continually divide, and it does the same thing in the throat. It's just at a later date. So cervical cancer usually starts pretty quickly in the teens to 20s to early 30s. Head and neck cancer usually is late 40s to 50s to 60s, but it's those same changes that the virus is causing inside the cell.
Excellent. Well, while most people associate human papillomavirus infection, HPV, as a sexually transmitted disease, it also carries the risk of developing into cancer in the genital, head, and neck areas, as we've been discussing. Prairie Doc spoke with a doctor in Sturgis who shares about the HPV vaccine and how it can save lives.
Dr. Joy Mueller is a doctor at the Monument Health Clinic in Sturgis and shares the importance of getting vaccinated against HPV.
Human papillomavirus is a virus that can cause a variety of cancers, head and neck cancers, but also vaginal, a lot of the female genital area and male genital area, and it can also cause genital warts.
Created in 2006, the vaccine helps prevent cancers that come from HPV by reducing the duration the body is sick.
It helps minimize the reaction your body has to that virus, in addition to the chance of it becoming a long-term infection.
Dr. Mueller says most people can recover from the virus. Those who don't may face a cancer diagnosis.
3 out of 4 people are exposed prior to the age of 30. It is a virus that most people are exposed to and they clear, but some people can have ongoing infections, and that's what leads to the cancers.
Dr. Mueller says the HPV vaccine is for both boys and girls and is usually administered when they're 11 years old. It's given in a combination with the meningitis and Tdap vaccines.
As long as you start this series before the age of 15, it's only 2 shots. And the second one is administered 6 months after the first one. If you start at age 15 or after, it's a 3-dose series because your body needs more of the vaccine to have the same effect.
Dr. Mueller says the HPV vaccine is safe with safety data available.
There's been no long-term adverse outcomes associated with the HPV vaccine.
So the HPV vaccine has been really helpful in helping prevent cervical cancer now and head and neck cancer. I don't know, have you seen a benefit, do you think?
So the data, because we have such a lag between when we think people are exposed to HPV and then when we think some of the natural innate immunity starts to wear off, especially in men, and then when they develop the cancer, which can be, a lag of at least 20, 30 plus years, the lowering of head and neck cancer rates has not been as apparent. So head and neck HPV-related cancer is still increasing. However, there are some early signals, especially in the Northeast, where the vaccine uptake rate was a little bit higher, that we're starting to see some lowering of the head and neck cancer rate related to HPV. But early signals, not as convincing as what we were seeing for cervical cancer.
Yeah. And can you get it more than once? You don't have to.
Oh, the HPV related head and neck cancer.
The HPV vaccine. How often do you get it? Do you know?
Interesting.
Often?
Yeah, no, I think that, standard guidelines are just one series. There are some interesting experiments out there, though, where people have tried using it as more of a therapeutic vaccine, especially for somebody who has pre-cancer changes in the cervix. And we've done that occasionally for people who have head and neck cancer. It's off-label. There's not a lot of data behind it, but yeah, I think the traditional answer is just one series.
Yeah. And it started before age 15. They only need 2 doses in the series. After age 15, need 3 because you have a better immune response as you're younger. So recommend usually starting at age 11, 12. Now they've expanded that starting at age 9 and even up to age 30. Mm-hmm. So, yeah. There are different stages of cancer. So now someone comes in, now you need to stage them. What does that mean? How does that work? Can you talk to that, Kyle?
This is where sometimes the patient and family get impatient because the staging of the cancer dictates what treatment needs to be. We need to know as much about this cancer as possible. A lot of the staging does fall in the ENT's world as far as their endoscopic evaluations of the tumor. They want to be able to see the tumor. They want to understand, is it creepy crawly? Is it touching more than one area in the head and neck area? We want to understand in great detail, are lymph nodes involved or not? We do CAT scans, we do PET scans, we do MRIs of the neck and the face. And again, it's just all about what is the stage? Is this localized? We're going to call this stage 1. Is it local and regional, meaning let's move the lymph nodes and we're dealing with more of a stage 3 type cancer? Because having that stage down is what dictates what treatment pathways we should go down.
And head and neck can be somewhat confusing because when the medical societies created the staging system, they created the stages only in reference to that individual cancer. So when someone comes in and we tell them, oh, you have stage 4 head and neck cancer, people start freaking out because they knew their family member that had stage 4 pancreatic cancer, stage 4 colon cancer, and that is a virtual death sentence. The fine print is in the head and neck, you can have stage 4 head and neck cancer and it's still curable.
Highly curable.
Highly curable. And so it's all in relative to other head and neck cancers, each specific type, and not in comparison to other cancers. So that, what really in the head and neck, what we talk about is, yes, the staging system is helpful for Dr. Armeson to kind of pick the correct modality of treatment and to design the treatment, but when it really comes down to it, it's, do you have metastatic disease? Is the cancer spread outside of the neck area to the rest of the body, or is it contained in the head and neck area? If it's contained in the head and neck area, it is still curable. If it's now spread outside of the head and neck area, that's where we start talking about we're probably not going to be able to cure this one.
And so how you decide surgery, radiation, chemotherapy?
So it's a group decision. Yep. So we actually just, both of us came from our head and neck conference. We do that every week. And that's radiation oncologists, medical oncologists who do the chemotherapy treatment, surgeons, pathologists, radiologists, dietitians, the whole team. And we look at all the information, the biopsy, the scans, the endoscopic evaluation, add all this information together. And then we look at the national guidelines, which are based on clinical trials and evidence. And as a team, we say, okay, here's what we think. Option 1, option 2, and then the patient weighs in, right? Because sometimes we have, also I'll give you an example. So for laryngeal cancer, there are some of the more advanced laryngeal cancers that are actually very large, invading the larynx, that on paper, based on the research studies, would probably have a higher cure rate if we actually did surgery and cut out the larynx, so-called a laryngectomy. However, most people say, I'm not really interested in that. Can you do anything else for me? And so
then they couldn't talk and
correct,
swallow.
Yes. They would be able to swallow. So swallowing's good
yeah.
with the laryngectomy, but talking is gone.
Yeah.
So now I don't know if anybody's ever seen those advertisements for anti-smoking where you have the little electric talking stick and you kind of sound like a robot. So anyway, the alternative to that is chemotherapy and radiation together that can cure a decent number of those cancer cases, maybe have a little bit lower survival, but patients say, you know what? Option 2 sounds good. And so that's part of that treatment decision making where we involve the patient, but we also give them our best guess of what we think would be most helpful for them.
How would you speak to when they're going to have some radiation, how you're deciding what you're going to do?
Yeah, so what's great is when we meet the patient and the family, often we've had our tumor board discussion. So I'm coming in knowing kind of the group thinking about the case. I've talked with the physicians that actually have met with them before. They've given me a picture of kind of their overall health. Are they even strong enough for a surgery if they wanted it? When we talk about radiation, again, it's trying to set those expectations. Again, are we going for cure? And then what does a curative intent pathway, look like, from a side effect profile, from a logistics standpoint? It's a multi-week commitment. Some people that live more rural, that could be challenging. There's some patients that would rather, think about surgery because they don't know how they could be away from the farm, for that extent of time.
Because they need to come to that place every day for it's several weeks. How long usually? 5 to 7 weeks, depending on the type of cancer. And it's just we don't want radiation out in the wild, so it's all in our vaults. And so a person would need to be with us once a day, Monday through Friday, for the 5 to 7 weeks. So it's a time commitment. Since we have an audience across South Dakota, just as a reminder, where can patients go? Do you know offhand in South Dakota?
Yeah. So in the Avera footprint, of course, we have Sioux Falls. We have cancer centers in Mitchell, Yankton, Aberdeen. We also have one in Marshall, Minnesota. Then, of course, Sanford has treatment here in Sioux Falls, and then Rapid City has radiation oncology. And I didn't say for Avera, we also built a peer clinic not that long ago.
Yeah, excellent.
Yeah, so we're trying to understand the geography, but just knowing that we have to have the resources, not just the radiation team, but for head and neck cancer, you need a multidisciplinary team. You need that support staff. You need the nurses that are able to sit with the patient and the family and will get them, through, just eating and drinking, sometimes from a nutrition standpoint.
So some patients maybe had surgery, now radiation, or just surgery. Now some patients had radiation and now surgery. Now what?
So you're saying once treatment is finished?
Once treatment's finished.
Yep. So then it's, and I think this is probably true of most people who go through the cancer journey, is a lot of watching and waiting and anxiety. Because we do not have a test that says, is there a single residual cancer cell left in your body? So we use a combination of time from the treatment plus scans. So usually our first set of scans are 3 months after the treatment finishes, and then regular clinical evaluation exam. And the farther we get out from treatment and the longer that we have those scans that don't show any cancer, the lower the odds of the cancer coming back. And for head and neck cancer, traditionally, most of our head and neck cancers, once you reach 5 years, we do consider those cured. And that is different than some other types of cancers where, say for certain breast cancers, that's kind of hanging over your head for the rest of your life. And so this is one that it is nice that at that 5-year mark, if
the chance of a recurrence is so low.
It's essentially considered cured at that point.
Great, great. For radiation then, I mean, I suppose you're hoping you don't have to see them again if the goal is cure. Are you following up with them then, or not?
We don't follow them as closely. We follow them, of course, when there's a side effect profile that we need to intervene and try to help with. Just as Chad explained, they really have ingrained in their clinic, this 5-year follow-up plan. That's most rigorous. Those first couple years, gets pulled back. We can do scopes and we can look into the head and neck area, in our clinic, and I can see things. But if I saw something of concern, I want Chad, confirming that. So I want their expertise.
Yeah. And so, however, like we talked to earlier, about maybe half of your patients or half of your treatments are more palliative, and where there might be ongoing treatments to help keep it at bay. How often is that successful?
So if you look at palliative radiation, if someone has a symptom, the odds that we could help with that symptom, like for bone pain, for example, the clinical trials that were done in the past would show that 80% of patients or more, got symptomatic improvement, in the cancer pain. If a tumor was bleeding, radiation can almost be kind of that radiation band-aid. It can kind of cauterize those oozing blood vessels and really slow things down. And again, it's trying to do enough to help without doing too much that the side effects start coming in. One challenge we have with radiation is that it's challenging to treat an area more than one time.
Gotcha.
So there is a lifetime limit of radiation dose to any one area. So if we've done curative intent radiation, and these are cases that we struggle with as a team most, if there's a recurrence in a radiated field, it's challenging because more radiation dose can be considered, but it comes with a much greater side effect profile. There's data for it, in appropriately selected patients. Surgical interventions after we've came in are much more challenging. We cause scar tissue and fibrosis, and some of those natural planes that a surgeon would use to get around a tumor and get it all clean kind of get obliterated. They end up being, everything's kind of sticky to themselves. So it's long hours in the OR for you in those types of cases.
And I suppose radiation itself could cause cancer. Is that seen very much?
It isn't a lot, but there's always a risk. We counsel every patient that when we use radiation to get rid of cancer, there's a tiny risk that a future malignancy could pop up. That risk is latent, so it's usually years and decades down the road. So the risk of us triggering a cancer, again, it isn't zero, but when we're doing curative intent, the risk of us causing a cancer is insanely, small compared to the risk of the cancer that's in the patient, as we're treating them. So.
Sure. And so we've had this goal of cure, and perhaps someone's looking really good, but there are side effects.
Correct.
What are some of those side effects that we're seeing then?
Yeah, and so it really depends on the modality of what was used. So if it was mainly surgery, then the side effects could be due to the volume loss of how much tissue we had to take out in what area. And that's a general principle of how we're making that decision of, do we do surgery, do we not do surgery and do chemo and radiation, especially because the head neck area is so functional, speaking, swallowing. We're looking at how much volume we have to take out and then trying to balance which treatment is going to limit those side effects. But in general, with surgery, the side effects are going to be usually short term, and then once they've healed, they go down quite a bit unless we actually had to take out quite a bit of tissue. And then we're talking about speaking and swallowing issues, sometimes some dysfunction of the shoulder or arm or neck if some of the nerves had to be sacrificed. With the radiation side of it, it's more the long-term effects from dry mouth, which can come from surgery as well, and then some of the swallowing dysfunction. And just to kind of go off on a little bit of tangent, but I think it goes to your question, what the field is really trying to look at now is we've almost done too good of a job of curing people, and we have a lot of people who are alive, but now they're alive and 5 years later they're developing some pretty bad swallowing problems, maybe even having to have a feeding tube put in. And so we're looking back and saying, okay, can we maintain these good cure rates, but figure out ways to adjust the treatment so that we can lower the side effects or the complications.
And that's especially true in those HPV-mediated, head and neck cancers. They tend to be a younger population. They tend to have less medical comorbidities, so their cancer and then the fallout and the long-term consequences of the treatment, become the number one medical issue. And being younger, it's just something that they have to deal with longer. So it's an important question.
But we don't want to give the impression that this is happening to everyone, because we could both cite for you people that went through chemotherapy and radiation, and you look at them and it's almost like you didn't do anything, and they're great and they're swallowing great and they feel great. You tend to, as a physician, you tend to remember the cases that catch your attention, where somebody's 5 years out, they're 55 years old, and now they're having a terrible time swallowing.
Do you get amazed, because I do sometimes, with the progress that patients can make with therapy and time?
Yeah, and that's just really, it's setting expectations up front, but then it's working with them not only during the treatment, but immediately afterwards, because some of that rehabilitation and maintenance it's during the treatment. Mm-hmm. It's not uncommon to potentially need a feeding tube, just for nutritional support, hydration support, medication support during, a radiation course. But even if they need feeding tube for some of the nutrition, we want them swallowing. We want to keep those muscles as strong as possible, as long as that swallow is safe. If they're coughing and choking and we're concerned that everything's getting to the lungs, then we have to pull back. But then it's that immediate, after treatment too. I feel some of our patients, some of the hardest points in their treatment course are those first few weeks after radiation is done. So one, they don't feel good. We just put them through something insanely hard. But when they're with us, we're with them every single day. And all of a sudden they go home, family's there to help, but they almost feel like they're on an island. So it's just having them back, making sure that they're, we're trying to work with their emotional support there too.
And what Kyle was saying earlier as far as the support team is critically important, because this is one of these conditions where an ounce of prevention is worth a pound of cure. And while you would think, oh, well, I just got to get through the treatment, and then afterwards I'll start working on my rehab. Right. This is something where putting your head down, just saying, you know what, this is not going to be fun, but I just have to do it, and really working on the swallowing and the rehab as you're going through the treatment makes a huge difference.
Yeah, good wisdom. Cancer clinical trials can be another option for patients going through their own cancer journey. Prairie Doc spoke with Ken Vinorny and Dr. Spanos about clinical trials and how they benefit both the patient and those diagnosed in the future.
After receiving a diagnosis of tongue cancer, Ken Vinorny says there are 3 things that have helped him through his cancer journey.
Prayer, positive attitude, and I work at St. Lawrence Catholic School. So I kept working over there, but I'd see these kids in the hallways, and they're smiling, and they say, "Good morning, Ken," and give me cards and things every day. So that just boosted me up. That helped so much. It was just amazing.
When Ken started his treatment for cancer, he was identified as someone who would be a good candidate for a clinical trial.
I said, if it will help somebody else, if there's a chance it'll help somebody else, bottom line. It's always been me. If I can help somebody with something, that's what I want to do.
For oral cavity cancer, surgery is almost always the initial option. And so it was never a doubt whether he was going to have surgery. It was just the question of how much and to what extent. And so what the clinical trial asked the question of, is it better to remove all the lymph nodes in the neck, or maybe we could just identify which lymph nodes drain from the cancer, take those out, and if they're positive, do a neck dissection. If they're negative, spare the patient from a large neck dissection. And that was the trial that he was accepted to.
Dr. Spanos says there is a broad spectrum of clinical trials, and these trials can be beneficial for future research and patients.
The reason we do clinical trials is we don't always have good evidence behind what is the best way to treat the cancer. And we're always trying to move forward to say, is there a better way to do this? And so one route would be to just start giving people things, not track whether it works, Well, we're not going to learn anything from that. Whereas a better way to do it is a rigorous comparison of old way, new way, and to say which one wins.
Plus, Avera has been working to bring more clinical trials to the region, giving patients more access to treatment close to home.
Quite often when people reach diseases such as cancer that are more advanced, they are sometimes having to travel quite a ways. So Chicago, Houston, even the East Coast to gain access to some treatments. And it's very nice that we are able to have some of those newer cutting edge treatments available in Sioux Falls so you can be around your family. You don't have to travel as far.
After surgery, Ken did have to go through radiation for 6 weeks.
When we have those concerning features from the result of the surgery that we think the patient's at higher risk of recurrence, then we apply some radiation treatments afterwards.
It was tough, but his welcome home made it worth it.
On my last day of radiation, they called us on the way home from school to say we're supposed to drive to the school. They have no idea what was going to happen. So we pulled in there, and all of the kids are lined up alongside the road on the sidewalk with cards and banners. Of course, all the teachers, and it was very, very emotional.
Ken continues to meet with Dr. Spanos every few months for follow-up. By participating in a clinical trial, he's potentially offering hope for future patients.
When you enroll in a clinical trial, it's not only for your own benefit, sometimes you don't benefit. And so clinical trials also are altruistic to help other people out.
Well, what a great story, and how, this patient's helping future patients too, and that's the benefit of some of these clinical trials. It takes the research to know, and you do some research in your practice.
I do, and especially related to the clinical trials, we're participating in research studies that are sponsored by either pharmaceutical companies or by the National Cancer Institute. And you can kind of break them down into categories of what happens when the regular cancer treatment didn't work, now the cancer's back or it's spread elsewhere. What can we do to try to help with that? And those are more advanced experimental therapies. But then there's the other side of it, which is kind of what we touched on earlier, which is, okay, there's some pretty nasty side effects from some of the treatments that we have. Is there any way to turn down the dial, still have those good outcomes, but limit the side effects? And so there's trials looking into immune therapy, looking into modifying the radiation dose. Can we safely do that? Alternative ways of combining treatments together, trying to figure out, can we do this better?
And as we get into some of the future perspectives of head and neck cancer, if you could speak on, immunotherapy, what is that?
So immunotherapy, in a very general sense, is the idea that we all have an immune system, and it's great at fighting off infections. And cancer, in general, tends to tell the immune system, don't pay attention to me, I'm not interesting, go away. And these immunotherapies use various different tools of basically reactivating the immune system to recognize the cancer as a foreign invader and something that should be attacked.
Yeah, and you see these commercials for Deflufenab or whatever. I made it up, but we're seeing more of these, aren't we?
Absolutely.
For across the spectrum of diseases and cancers.
Yep.
And as part of that, as we're DNA sequencing cancers, is that what's helping us get more understanding and use these tools, or is that even a different treatment modality?
It's all together. So the sequencing is basically opening up the box and saying, all those secrets that were within the cancer, can we learn about how the cancer is functioning? And some of the information that we get back from the sequencing or the genetic analysis of the cancer can help us understand how to apply immunotherapy, but some of those things actually say this certain pathway or this programming in the cancer cell is wrong or activating this pathway. Can we go in and use a specific drug to block that? And some of the really interesting clinical trials are actually using that type of approach plus the immune therapy together. So kind of like peanut butter and jelly, just add them together, it's much better.
Nice analogy.
Yeah,
thank you. So, and as we alluded to there, sometimes we may consider a less radiation dose? Is that something we're doing much of, or?
We hope to in the future, do more of it. So anytime you change a standard of care pathway, you need the data. So as we learn that we can use radiation to cure head and neck cancers or other cancers, they did clinical trials in the past, where they were giving more dose or in a different style. They compared it to what the standard was at that time. So, so say that this was a curative, HPV positive head and neck cancer. Our standard is any cancer that could be seen, would get that 7 weeks of radiation. And then the areas in between where you don't see cancer, but where cancer cells could be hiding, are still getting the equivalent of maybe 5 or 6 weeks. So still a strong dose. So, the question is, if you have a favorable tumor, can you pull back? But how can you pull back to the point where you don't start risking cure rates? So de-escalation needs to be done in a rigorous manner too, as far as clinical trial design. And we have some interesting data that says in the right patient, in the right tumor, in someone who's not a smoker, that you potentially can. So people are working as fast as they can on it, but just to enroll in a clinical trial, get the patients treated into that follow-up mode, so you actually can learn what happens at year 1, year 2, year 3, year 5. It just takes that time and patience.
What are some things that excite you about your radiation oncology, your practice in the next 5-10 years?
Yeah, so the interplay with immunotherapy. Can we have immunotherapy be part of radiation and chemotherapy? As far as improving outcomes. We're good between surgery and radiation. Often we are able to control the primary tumor. If you look at overall survival, often what drives a 5-year overall survival is metastatic disease. So getting that whole body protection. You have to eradicate the disease that's there, make sure it doesn't come back in the rest of the body. So there's lots of interesting studies. What is the best time to give immunotherapy? Do you want it with the radiation? Do you want it before surgery? Do you want it just after everything's done? And then just from a radiation standpoint, we're just getting so much better too with more like our stereotactic techniques. Instead of treating big areas for long periods of time, can we, in the right patient, right tumor, can we give very high doses to a small area? If you treat a small area, less side effects, but that dose is intensified. So actually, can you, eradicate the tumor better? So there's, lots of, great stuff, going forward.
Any other particular things you're excited about in the future in your practice?
Yeah, so I've been fortunate to be part of some clinical trials where we've actually given some treatments prior to actually doing surgery. And every now and again, you'll have a spectacular case where the cancer will completely go away. And those just give you a glimpse at, if we could just crack this code, if we could just figure this out. If you were a cancer patient, if I was a cancer patient, what would you want? Walk into the doctor's office, hey, Dr. Ellsworth, I've got this lump on my neck. Oh, no problem. Let me just inject this one thing. Boom, it's gone, right? I mean, it sounds like a fairy tale or magic, but there is a hint that for some patients out there, we might be able to figure out a way to not do surgery, hate to say it, not do radiation, but deliver a treatment that would then make the cancer go away and cure it. And that's, I think, what I find most exciting.
Absolutely. And of course, granted, there's plenty of things we do nowadays that would have blown doctors' minds 100 years ago. So there is hope.
Absolutely.
There is hope, yeah. Or if only we could prevent cancer in the first place with a vaccine.
Even better. Hey, go get your HPV vaccine, right?
Exactly. And so, a couple questions about, will it affect my ability or my speech, or my ability to chew and swallow? Do you see that sometimes?
Absolutely, and that answer is individual and personal, and it all depends on where is the tumor, how big is the tumor, how much are we going to need to remove with surgery, or if it's not a surgical case, how wide of a field do we have to treat with radiation? And so that one is a very individual decision. I would say most of our patients do pretty well as far as speaking and swallowing, but there are those exceptions, especially for people who come in with very large tumors, that it is going to be a permanent change to speaking or swallowing.
And another prime example of don't ignore it.
Yes.
Get in, get seen. The sooner we can help, the sooner we can help.
Smaller is better.
Smaller is better, absolutely. Are dentists involved?
Absolutely. So we rely on dentists heavily because radiation.
Yeah, so just whenever we design radiation, one of our main goals as far as protecting is those salivary glands. So the big ones that are easier protected, the parotid glands are up higher. Dry mouth is no fun. I know someone has a dry mouth when I see them in follow-up because they have a bottle of water sitting there and they're sipping on it as we talk. Okay. It is subjective. I meet some patients when I do an oral exam, I see a decent amount of saliva, but they feel dry. And I've had some, the mouth looks parched, and they're like, oh no, I'm fine. So it is subjective. Sure. But once you don't have as much saliva, you don't have that cleansing effect as far as saliva keeping your teeth clean. Sugar is going to stick to the teeth longer. So we just need that meticulous dental care. That's patients with their home regimen, but working closely with their dentist. We don't even start radiation, if at all possible, unless we have dental clearance. We have them see their dentist, establish care, and have them start working on what a prophylactic plan, as far as fluoride and cleanings would look like.
Is plastic surgery involved too?
Yes, so some centers utilize a plastic surgeon to help with the reconstruction. Quite often, and that's true of our center, there's a subgroup of head neck surgeons that do essentially plastic surgery or reconstructive surgery. And so in general, if you have a large tumor that is going to have surgery, then the reconstructive surgery or the plastic surgery is all part of the surgical treatment plan.
What kind of rates are we talking about the risk of cancer recurring?
It really depends on the individual site and the stage. So for example, a small, very small oral cavity cancer, early stage cancer, risk of recurrence might be 10-15%. Whereas if you have a large, more like stage 4 laryngeal cancer or throat cancer, some of those recurrence rates can be even up to 40% at 5 years. So it's very individual.
Especially with a long smoking history.
Yeah.
What's amazing is that if a patient with head and neck cancer quits smoking at the time of diagnosis, so if they quit smoking between their diagnosis and their first oncologic treatment, cure rates are 20% higher.
Why is it that smoking, yes, we all know smoking increases your risk of lung cancer, but we know that actually smoking increases your risk of pretty much all cancers. Why is that?
I will just speak to what I know, which is more head and neck cancer. So in the head and neck, the theory is that the tobacco smoke, and especially in combination with alcohol, tends to dissolve the nasty chemicals that are in the tobacco smoke, and it actually goes straight into the cells in the mouth and the throat area, and then it goes in and it starts breaking the DNA and causing errors in the programming of the cells, but then leads to the eventual cancer formation.
Yeah. And I would imagine there's some chronic irritation and inflammation involved
Absolutely.
too. And we should, of course, mention that not just smoking, but chewing tobacco is going to be a major factor with head and neck cancer.
Although less. It's still bad, but if you look at the studies, smoking by far and away is a much higher risk than chewing tobacco. And the issue with chewing tobacco, though, is it's kind of like going to the casino. When you pull that slot machine lever, you don't know. Are you going to win or are you going to lose? And the problem with chewing tobacco is we can all cite cases of that 18-year-old, that 20-year-old that came in, had only been using it for a few years, and now they have a horrible advanced head and neck cancer. Yeah. But statistically, most people who use the chewing tobacco, it's not as high of a risk as the smoking.
Kyle, in our final minutes here, what is one of the most rewarding things of what you do?
Is working with the patient and their family. I feel that I did my job when patients tell me at the end of our conversation, I know more about my cancer now and my treatment pathway than when I came in the room. Because it is mutual decision making. We're asking them to go through a toxic treatment pathway. I want them to understand why. And if I'm going to point a radiation beam at someone, I want them to fully understand.
Excellent. How about you, Chad?
I think it would be very similar that I can think of certain cases where patients came in very anxious, very scared, and you kind of remember that the way they were before they came in, and then 5 years later, they're there with their family, life is good, maybe they started exercising, they quit smoking. In a way, they almost feel better, and you remember those cases because you say, well, maybe I actually did help a few people here, and that, I think, is very satisfying.
So final words of advice: don't smoke, don't chew, get your HPV vaccine at a young age, Any other, and watch your alcohol use, good scene, or any other words of
and
advice.
don't avoid your doctor. Like, sometimes medicine is scary and you're worried that you walk into the doctor's office and they're going to start doing all kinds of things to you. But if you have symptoms that are persistent, go see your PA, your nurse practitioner, your doctor, go get checked out, and don't ignore things.
Yeah. Final 30-second advice.
Yeah, and if you're going through these treatments, again, everyone's there to help you. Ask for the help.
Yeah.
And often we know what help you need, and please accept it, if we're offered it.
Yeah. This was a great example of just the team in place. All the different doctors, all the different therapists and rehab people and primary care docs and the people driving them to the radiation treatments, the family members. It takes a village. It takes support.
Physical therapy, speech therapy. Like there's only 2 people sitting at the table here. There's probably 20 to 30 people behind the scenes helping these patients get through.
Well, thank you both so much for coming tonight. We'll be back after this.
Overwhelmed with the amount of information available? Not sure which sites to trust? Head to the Prairie Doc YouTube channel today to access all previous On Call with the Prairie Doc episodes. And make sure to join us most Thursdays on SDPB or streaming on our Prairie Doc Facebook page.
Thank you so much to our guests, Dr. Spanos and Dr. Armeson, for volunteering their time to help us learn more about head and neck cancer. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on South Dakota Public Broadcasting Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Hearing loss can affect everyone from babies to our older generation, and the impacts of hearing loss are broad and can be profound. Solutions for hearing loss, next time on Call with the Prairie Doc.
My name is Carter Home, and I serve on the board of directors of the Healing Words Foundation, the nonprofit that runs Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,